This is Dr. Yakov Lawrence. I am a radiation oncologist from the Sheba Medical Center, and today we're going to talk about esophageal cancer. This is an overview of the lecture, a brief introduction. Then we're going to talk about the anatomy, the epidemiology of esophageal cancer, causes, symptoms, diagnosis, a few words about staging and treatment. And then, because this is the first lecture I'm also going to just mention in passing some words about some cancer resources which those who are interested in oncology, it's definitely worth knowing about. Before I start the lecture, just say a few words about myself. I'm originally from London. I did my medical studies in London, and then I made Aliyah to Israel. I first of all qualified in internal medicine and subsequently in radiation oncology. I also spent a couple of years in Philadelphia. So, this is the anatomy. On the left-hand side, you can see the esophagus, and you can see here the depth. It's traditionally measured as if you were putting an endoscope in, hence the mouth is 0 centimeters. And when you get down to the GE junction, the gastroesophageal cancer, gastroesophageal junction, it's 40 centimeters. So most of the cases of esophageal cancer we're going to talk about today are from 20 to 40 centimeters. If it's above 20 centimeters, which is the thoracic inlet, then that is really considered a cancer of the head and neck, and it's very difficult to operate in that area, and patients tend to receive chemoradiation, and we won't talk about any more today. Likewise, tumors which are right at the bottom of the esophagus, what's called the G junction, they can be treated either as an esophageal cancer or as a gastric cancer, and so there are kind of multiple options for these patients. Now, overall, esophageal cancer is a bad cancer. It's not only a bad cancer, it's a bad cancer whose incidence appears to be increasing. In the Oxford textbook of oncology that I used when I was a resident, it states that anybody who's cured of esophageal cancer, well, that's an act of God. Now, I think that's a little pessimistic. I think it's got a little bit better, but I think that just reminds us just how bad this disease is. And if one understands the anatomy, then we can begin to understand why it's a bad disease. First of all, here there's a very rich lymphatic drainage in the submucosa, which predisposes to lesions spreading up and down the esophagus. Second of all, there is direct connection between this lymphatic drainage and the thoracic duct, which means that the cancer sends metastases early. And thirdly, there is no serosa. So serosa is that smooth tissue membrane which envelopes most of the organs in the thorax and in the abdomen. The esophagus does not have such an envelope, and that predisposes the cancers to spread locally. Looking at incidence, this graph just covers a 20-year period from 1984 to 2004, looking at various countries in the West, and you can see the incidence has very quickly increased. This is another way of looking at those same numbers, but this time looking over a 60-year period, looking at people who were born in 1905 or people who were born in 1965, and what you see here is that the lifetime risk relative to those people who were born in 1905. So you can see that somebody who was born in 1965 had a 15 times increased risk of developing cancer compared to somebody who was born in 1905. So a tremendous increase in incidence. A rather pessimistic sentence I found in a recently published article in the American Journal of Gastroenterology is that by 2030, 1 in 100 men in the Netherlands and the UK are predicted to be diagnosed with esophageal carcinoma during their lifetime. Really tremendously large numbers, and I think the figures in the United States are probably very similar. Now, what we call esophageal cancer is really two different cancers. One is squamous cell carcinoma, and the other is adenocarcinoma, two different histological types. The squamous cell carcinoma are those which tend to appear in the upper and mid esophagus. They are associated typically with tobacco and smoking, whereas adenocarcinoma is especially in the lower esophagus, in the GE junction area, and that is most commonly associated with reflux, Barrett's esophagus, and obesity. I'm looking at this graph of incidence from the United States. You can see that over time, from 2000 to 2016, the incidence of squamous cell carcinoma has dropped very sharply, presumably due to a decrease in smoking. However, the incidence of adenocarcinoma is constant or has slightly increased, and certainly the proportion of cases which are due to adenocarcinoma has very, very much increased. So a word about Barrett's esophagus, first described just 50, 60 years ago. It's associated with gastric reflux. We see it in 2 to 3% of the population, but these patients have a 10 times increased risk of developing esophageal cancer. Now, it's not my job today to talk about the treatment of Barrett's esophagus, but generally speaking, these patients need to be treated with aggressive anti-acid therapy, which, as far as I'm aware, is with anti-proton pump inhibitors, and also they need to be under regular surveillance with endoscopy. Looking at this graph here on the y-axis, you can see abdominal circumference, and on the on the x-axis you can see abdominal circumference, and on the y-axis you can see the risk of developing Barrett's esophagus, and you can see there's a very close association. The bigger your abdominal circumference, the higher the risk of Barrett's. Also in the literature, and this is something I kind of learned when preparing this lecture, is they talk about two types of obesity. There's abdominal obesity and there's more hip-based obesity, and what's really bad for Barrett's esophagus is more the abdominal obesity. So it's not just your weight, it's also taking into account how much of that is put on in your abdominal area. Looking at these graphs, these graphs really demonstrate the obesity epidemic in the United States, although again it's the same in the entire Western world. In 1985, you can see that the incidence of obesity was fairly low, and in 2010 it's really enormous that the map has changed color. So when we're talking about the risk factors for esophageal cancer, this is from a nice review that's published in the New England Journal a number of years ago. You can see here it's separated between those which cause squamous cell carcinoma, that's again the mid and upper esophagus, which has become rarer today, and adenocarcinoma. So just looking at squamous cell carcinoma, we mentioned alcohol and tobacco. There's also achalasia, caustic injury to esophagus. I've seen that a few times when patients, often psychiatric patients or suicidal patients, have drunk a caustic substance, and that causes an esophageal cancer years later. There's also a rare genetic condition called tylosis, which causes thickening of the skin of the palm and the feet, and also esophageal cancer. And then there's this rare disease called Plummer-Vinson syndrome, which is like an association between iron deficiency anemia, glossitis, difficulty swallowing, esophageal webs, and also squamous cell carcinoma of the esophagus. At least in my time, it's a rare disease, but kind of frequently kind of thing that pops up on exams. In terms of adenocarcinoma, as we mentioned, it's all to do with Barrett's esophagus and obesity. They also mention tobacco use, and both types of cancer can be associated with exposure to ionizing radiation. So what are the symptoms of this disease? So classically, it's people complaining about food getting stuck in their esophagus. They can have some heartburn, some weight loss, persistent cough, and more rarely they may complain of a kind of mass in the Virchow's node, supraclavicular area, or back pain, which could be metastasis. I'll just mention a clinical observation of mine is when patients complain about food getting stuck, they're actually pretty accurate in saying where it is. So a patient with upper esophageal cancer often complain of the food getting stuck higher up, and lower esophageal cancer, they often complain of it getting stuck lower down. In terms of diagnosis, the bottom line is endoscopy. That's the way you diagnose esophageal cancer. CT scan is more important. We'll get to it a bit later in terms of seeing if the disease has spread or not. But the CT scan, in fact, for the entire esophageal, for an entire GI tract, esophagus, colon, rectum, is not a good way for finding tumors. So just because somebody's had a normal CT scan, that doesn't mean that they don't have a cancer of anywhere in their GI tract. Likewise, a breath test, beloved of what I see many family doctors. They may tell you if you have Helicobacter pylori as a cause of gastric ulcer. It doesn't tell you anything about whether you have esophageal cancer or not. This is a bit of a sore point with me. Almost all the patients I see in my clinic who've got esophageal or for that matter gastric cancer have just wasted too much time in their family practices, getting breath tests done and going on for trials of antibiotics. And these are precious months are wasted when the disease could have been diagnosed at an earlier stage. So here we see a picture of somebody doing an endoscopy, and here we see a mass growing out of the wall of the esophagus. This is a picture of a barium swallow, done much less than it used to be, but still done occasionally. And here you can see a thinning of the esophagus where the contrast hardly passes, and this is called a stenotic lesion, or an apple core, because it looks like an apple core somebody's eaten out of. And then before this, you can see that it gets very wide, the esophagus, and this is called the pre-stenotic dilatation. So here's the pre-stenotic dilatation, and here is the apple core finding. A PET-CT, these are a combination of a CT scan and a PET scan. The PET scan measures uptake of radioactive glucose, and tumors are almost always very avid glucose eaters, and so it's a very good way of seeing the tumor and lymph nodes. So here you can see the tumor, and here you can see an associated lymph node. Here is an axial cut, and you can see a thickened esophageal wall. Here you can see the lymph node over here, and here you can see, and this part happens to be a normal esophagus. That's a nice comparison. That's a normal esophagus. Here's a thickened esophagus. Perhaps you can appreciate now why CT isn't a great way to see esophageal cancer. The findings are quite subtle, and here you can see an enlarged node. An investigation that you often see discussed in the literature and recommended is endoscopic ultrasound, which is a very good way of differentiating between very early and early stage tumors. You can see how much the tumor invades into the esophageal wall. In terms of staging, the standard system is the AJCC, which splits into TNM. So here this T staging goes from T1 to T4. T1 is what it invades up to the submucosa. T2 invades into the muscularis propria, T3 into the adventitia, and T4 into adjacent structures. For instance, if it's invading the trachea, there'll be then a T4 cancer. T1 is split up into T1A, which gets until the muscularis propria, and T1B, which invades the submucosa. And that's an important distinction because it's the T1As which can undergo local resection, as we'll mention later, and if you already have a T1B, then you need to undergo a formal esophagectomy, a large operation. In terms of end stage, it really depends how many lymph nodes you have. To be honest, from a clinical perspective, it doesn't really matter if you're N1, N2, N3 in terms of how we manage a patient. N3 is statistically worse than N2, worse than N1, but all these patients are actually treated the same way, and then the M stage is if you have metastases or not. So moving to treatment, what are the goals of treatment? Well, we want to control the disease, we want to palliate the patient, and also with these patients we need to think about their nutritional input. So one of those buzzwords in modern medicine is multidisciplinary care. So it's true for all cancers, but especially for gastrointestinal cancers, and especially for esophageal cancers, you want the input of a dietitian to help you take care of these patients. So this perhaps is the most important slide, and this is an overview of how we treat these patients. So patients with very early disease, and I'm already going to tell you that these patients are extremely rare in Israel, in America, in the West. They see lots of these very early T1A and 0 patients in places like South Korea and Japan. We don't really diagnose them that early, but if you occasionally patients you have like this, then it's good to do an endoscopic mucosal resection, and you can avoid doing an enormous operation. If you already have a T1B tumor, even if there aren't lymph nodes, then these patients already, ideally need to undergo a esophagectomy, which is always a very large operation. If it's a T2 lesion, or there are positive lymph nodes, then doing an operation alone is simply not good enough, and then you need to have what we call triple modality treatment, which is a combination of preoperative radiation therapy combined with chemotherapy, and then after they recover from that, they undergo resection. We're going to talk about it in a moment. It's called the CROSS protocol. And then if you have patients who are metastatic, then the basic thing we give them is some kind of combination of chemotherapy. Everything I just said is for the young and fit. For patients who are less well or elderly, then we tend to say that triple modality therapy is too much for them. We may say that operation is too much for them, and then you can give them chemoradiation alone, which isn't a great treatment, but it does have a 20% cure rate. And if they're metastatic, then again, giving 2 chemotherapies may be too much for this population, and you may give them single chemotherapy. You may decide that no chemotherapy is worth giving in this population. Exactly where you cut the line between the young and fit population and the less fit elderly, in my clinical duties, we spend a lot of time arguing about where a patient fits on this spectrum. So here's a slide of endoscopic mucosal resection. It's done by our colleagues in gastroenterology. I don't claim to know a lot about it, but you basically inject some saline under the lesion. It makes it pop up, and then you can kind of slice off or suck up the lesion. And then it's very important in these procedures to examine the pathology to check that you got everything out. Classically in oncology, the entire world of oncology, we used to talk about the 3 pillars of oncology, which was some combination of radiotherapy, surgery, and chemotherapy. And more recently, we have the addition of immunotherapy, and we're going to go through each of these in turn. First, the esophagectomy. So first of all, in the world of surgery, they really started doing esophagectomies really very late. I think in 1913, this is a picture of the first gentleman to undergo such operation. Before that, everybody died, and even after that, many of the patients died having undergone esophagectomy. And the reason for that was it's a very long, complex operation. They often have anastomotic leaks, multiple times the infections, the patients are malnourished. For these reasons, it's a challenging operation. Now, today the mortality is much, much, much less than it was all those decades ago. However, it remains a major operation. Now, in terms of esophagectomy, when talking to a surgeon, there's some terms you need to know. There are basically 2 approaches. The surgeon may decide to go via open the thorax and basically take the esophagus out that way. That's called a transthoracic or Ivor-Lewis approach. Or you may decide to go via the abdomen, and that's called a transhiatal approach, going down and then pulling it down. Other terms they can use, they may have an open approach where they literally open up or the thorax or the abdomen, or there's often use today, a minimally invasive approach, also nicknamed keyhole surgery. And more recently, there's a combination of keyhole surgery with a robot, where the surgeon himself isn't actually touching the patient. He is actually a few meters away, operating a robot. Another important distinction regarding surgical approaches is whether a gastric pull-up is performed or colonic interposition. We're going to see that in the next slide. So, after you take the esophagus out, you can pull up the stomach, and that forms a kind of comes in place of the esophagus. That's not always possible, and so sometimes the surgeon has to create a kind of neo-esophagus, and he does that by cutting out a piece of bowel and then putting it in the thorax to make a new esophagus. Now, exactly when the surgeon decides to do which procedure, which approach, thorax, transhiatal, pull-up, neo-esophagus, that's really a surgical decision that I really don't get involved in, and I don't even quite understand, but I think it's important for your students to understand these various different options. In terms of chemotherapy, so here we make a distinction between people who are undergoing some form of curative combination of chemoradiation, and that's when we give the chemotherapy simultaneous with the radiation. And then one of the classic combinations is paclitaxel and carboplatin, whereas patients who are getting treatment for metastatic disease, as we mentioned earlier, if they're young and fit, we may give some kind of combination treatment like FOLFOX, which is a combination of oxaliplatin and 5-FU. However, if they're elderly or less fit, they're more likely to get some kind of single agent. In terms of biological agents, the one drug that's kind of been proven is for a minority of patients, 20% who express a molecule called HER2, then you can give them trastuzumab or Herceptin, a drug more often used in breast cancer. In terms of radiotherapy, which is where I get involved on a daily basis, so just to give you a very brief overview of what it involves, there tend to be 4 steps in the radiotherapy process. First of all, obviously meeting the patient, explaining to them. The next step is we do a simulation, which in this day and age is simply a special type of CT scan in order to get a map of their anatomy. After that, the patient goes home, and we tend to spend about 7 to 10 days planning their treatment, which is basically the physician and a physicist working with their CT scan to plan the treatment. And then when it's ready, then we start the radiation, often, as I said, together with chemotherapy. The treatment is often given on a daily basis, once a day, 5 days a week for 4 to 5 to 6 weeks, depending on the precise protocol that we're giving. The daily treatment tends to last about 10 minutes. So yes, it may be 23, 25 treatments, which sounds a lot, but at least the patient only has to come to the department for about 10 minutes and then go home again. Maybe a bit of waiting time, but okay. Here we can see a radiation plan. Here you can see the color. The red there is the dose that we're planning to give. And as I mentioned earlier, because the esophagus has a very rich lymphatic plexus, tumors have a tendency to spread up or down the esophagus. And therefore, even though the tumor may just be in one part of the esophagus, we often go quite a bit above and below in order to cover that lymphatic spread. Now, as part of this lecture, I was asked to supply you with an article to read, and the one I'd like to, I hope that you read and I'd like to discuss with you is the cross study. This was a paper published in the New England Journal. It was a group from the Netherlands, and it really changed the way we treat esophageal cancer. I just mentioned, before this study came out, there were many opinions and approaches about the best way to treat locally advanced esophageal cancer. Some people thought the best thing to do was to operate. Some people thought operate and then give chemotherapy. Some people did the opposite, chemotherapy and then operate. Some people did radiation without operation. All kinds of combinations. Anything went. Once this paper came out, it really defined the best thing to do. Even though this paper only this prospective clinical trial only compared two options, which was operation alone versus chemoradiation operation. One of the things that it showed, and we'll say at the moment, is that it had the best results really ever noted for esophageal cancer. And so I'm only going to give you the bottom line now. That combination of chemotherapy followed by radiation has become the standard of care for patients with locally advanced, non-metastatic esophageal cancer. So just to go through these slides in detail, they started off with 840 patients. Many were excluded. Probably some of them were metastatic. Probably some of them weren't strong enough to undergo what's really quite a toxic treatment. In the end, they got down to 370 patients, 368 who entered the trial. Half went to surgery alone, and half went to chemoradiation followed by surgery. This is the adverse events of these patients, and you can see, and this is the bottom. These are the patients who got chemoradiation first. These are patients who got surgery alone. You can see that these actually numbers are extremely similar. It's interesting to note there was less leakage in patients who had the more aggressive treatment, which really kind of indicates to me that the causes of leakage after are more related to the tumor than related to the treatment. And one thing that there was more of in the chemoradiation arm is cardiac and pulmonary complications. Only a small increase, but that's because those are two areas which are irradiated when we treat these patients. Another thing to point out in patients getting a neoadjuvant chemoradiation, their main side effect is they develop quite bad pain on swallowing, dysphagia. That tends to start about after 2 weeks of treatment and continue for about 4 weeks or so. And that's due to some kind of internal radiation burn of the esophagus. It's always important to tell these patients that their symptoms are going to get worse before they get better. And most of these patients do require some form of opioid, morphine-like medication to help them get over the period. They often require intravenous fluids, and some of them may even require some kind of nutritional support, such as TPN, and we'll come back to that later. This is the survival curve. So this is a Kaplan-Meier curve. So on the y-axis you've got percentage surviving. On the x-axis we have time. So you see at time 0 everybody was alive, and over time people died. The heavy black line is the experimental arm, the chemoradiation, and the dotted line is a surgery alone. And here you can see in terms of median survival, and you read that by looking at the 50% figure on the y-axis. In those who underwent surgery alone, it was only 24 months, and of those who underwent chemoradiation, it was 49.4 months. So a big difference in median overall survival. And in terms of 5-year survival, again, unfortunately, the majority of patients died, but it was a 47% those getting chemoradiation versus just 34% in those who got surgery alone. So that's a 13% difference in 5-year survival. As we mentioned earlier, there are really two types of esophageal cancer. There's adenocarcinoma and squamous cell carcinoma. And in this graph, they split it up according to histology. And you can see here that it was really the squamous cell carcinoma who had an enormous difference between the two treatment arms. Adenocarcinoma did also benefit from neoadjuvant treatment, but less so than the squamous cell carcinoma. It was significant for both these arms, but the squamous cell carcinoma benefited even more. I'm going to skip that slide. So regarding immunotherapy, that is the big new thing in cancer treatment. However, even though immunotherapy is approved by the FDA for esophageal cancer, I got to tell you the bottom line is it's very disappointing, at least using what we have today. So with the Keytruda, also known as pembrolizumab, they're just 20% response rate. It means if you give it to patients, only 1 out of 5 patients will have their tumor shrink by this treatment. and also it's not for any patient. It's only for those who have tumors which express the PD-L1 protein. So, I'm not a medical oncologist, but really quite disappointing results. Let's talk about palliation. So, if patients have difficulty swallowing, like most of them do, then you can consider giving them systemic chemotherapy. Maybe I just go back a step. I just say this is patients, let's say they got metastatic disease, so we're not talking about cure. We just want to make them feel better. So what are the options? So you give them systemic chemotherapy, which can definitely help. However, chemotherapy has its own side effects, alopecia, losing hair, weakening the immune system. You can give them radiation. Radiation actually is really pretty effective, and it can keep that esophagus open for about 8, 9, 10 months. The problem is that they often feel less good before they feel good, because as we mentioned before, there's often that radiation burn is the first thing patients experience. You can put in a stent. These are kind of metal mesh stents that you put in the esophagus. I have to tell you, in all my years in clinical practice, I can really only remember one patient who said, "Thank you for having a stent put in." These stents can cause bad symptoms, they can cause pain, and they can cause reflux. So I haven't seen much, benefit from these stents, but they definitely exist. In terms of trying to get calories to your patients who can't swallow, you've basically got two options. One option is a PEG, a percutaneous endoscopic gastostomy, and that's a kind of a plastic tube which connects the stomach to the outside. Or you can give them food via the vein, which is called total parenteral nutrition, TPN. Let's talk about this for a few minutes. First of all, just be aware that once again, patients don't really say thank you for having neither a PEG nor TPN. They don't really, most of us enjoy eating. It's a pleasurable experience. There's really nothing pleasurable about having a PEG or a TPN. So as oncologists, even though especially family members will push patients to have a PEG or TPN, the patients are often, if they understand things, less enthusiastic, and us oncologists are often less enthusiastic, because sometimes it just makes the suffering continue for longer. Nonetheless, sometimes it is important to do these interventions, and if the patients want it, then we definitely then often we will do these things for them. A few words. We try not to do TPN because that is more complicated. Patients need to have some kind of permanent venous access, often a PEEK line, which is a plastic line that goes into the arm but stays there for a long time. These can get infected and can be a bit dangerous. You need special equipment at home. And so it can be better to put in a PEG. There are two problems with PEGs, however. One is for patients who've got blocked esophagus, it's actually more difficult to put them in. You can't really do endoscopy. You may need an open operation. The second problem with PEGs is, let's say this is a curative patient who, let's say they're having that chemoradiation before operation and they can't swallow and they're losing calories. You want to give them food. Often the surgeons will request from us not to put in a PEG because it makes their operation more complicated later on. So for patients undergoing a preoperative chemoradiation, we often prefer to give them TPN in order not to make the surgeon's life more complicated. So in my last couple of slides, I want to tell you about some resources which are available for free on the web, and it's definitely worth knowing about, especially for people interested in oncology or people with family members cancer. You can get very accurate, up-to-date information free of charge. So one resource is the NCCN. This is a network of academic cancer centers in the United States. They have many guidelines for every common cancer type and even some of the rarer cancer types. And they're updated at least twice a year. They're really excellent. They've really set the standard of care in the Western world. all of their documents have the same design. They have this kind of flowchart kind of thing. So in this flowchart, it says somebody with squamous cell carcinoma, it's this stage, it's an early stage, do a esophagectomy. It's a more advanced stage, and we recommend preoperative chemoradiation or definitive chemoradiation. And so it takes you through step by step, and it's got hyperlinks, and you can click on it, and it's really a very pleasurable resource to use. I have to say, over time, it's got more and more complicated. I remember 10 years ago, the pathways were much simpler, but nonetheless, it's a very up-to-date resource, completely free of charge. You have to register, but it's free of charge. They also have pages which is more text-based, and it says the principles of endoscopic staging. They also got another page called the principles of radiation, the principles of surgery, and so you can get more depth there. It has the staging details, and then at the end, after they finish with all their guidelines, they have typically 20-30 pages of well-written text which explains how they got to the decisions they made in all those flowcharts. Everything's with references, and it's very well written. And and here it tells you, can see it says, I downloaded this last night. It says discussion update in progress, to tell you that we're about to update these guidelines a little bit. Another resource, by the way, is Up to Date, if you have access to that, which is really maybe doesn't quite have the detail, but in terms of a general overview is really excellent. Another thing that nobody ever told me as a medical student, and I wish I hadn't done, is that for people who are interested in oncology, then you can join these different cancer societies. You can join these cancer societies either for a nominal fee of $50, or I think for medical students it may be completely free. And it's a great thing to do. You get access to resources, you can network, you maybe have a chance to go to one of their big meetings. For somebody who knows that they're interested in cancer, and by the way, this advice is the same for any area of medicine. Somebody who's interested in obs and gynae, so the American Society of Obstetrics and Gynecology, whatever you're interested in, have these big American, also for that matter European societies, well worth looking into and learning about these resources. So the four which are kind of relevant to cancers: ASCO, which is the enormous society, and that's really all to do with clinical, all to do with medical oncology, even though they include all the other specialties, radiation, surgery as well, but especially medical oncology. You have ASTRO, which is the American Society for Radiation Oncology. You've got SSO, which is, I don't know so much, but that is for surgical oncology. And then you've got AACR, which is the Organization for Cancer Research. So that's it. You're welcome to ask me questions. I have here my Israeli phone number and my email, and you're welcome to drop me a line. Also, I mentioned for people interested in residency, especially in radiation oncology residency, it really is critical to do research and have published papers while you are a resident before you submit your application forms. And I tend to have some research projects going on. And for serious people who are dedicated, you're also welcome to drop me a line. Thank you very much.